Welcome back. My name is Dr. Eric Pearson, and I'm so pumped that you're joining us for another video. I hope that you've enjoyed the first few on the metabolic response to injury, the surgical nutrition videos. If you haven't actually seen those yet, go ahead, hit the cards up here. If you haven't had a chance to subscribe, go ahead, subscribe, then you'll know when all these videos are coming out. And now we're going to jump into specific electrolyte disturbances. So let's go. We're going to start with sodium. So sodium is the predominant extracellular cation, and this is the predominant determinant of plasma osmolarity. And I'll put the equation up here so you get an idea of when you look at 2 times the plasma sodium concentration, that makes up the majority of plasma osmolarities. And so that gives you a good idea of how important sodium is. And why is osmolarity important? It's important because in that first video on the metabolic response to injury, we talked about the fact that when you're injured, you get ADH secretion. Now, what are some of the big stimulants of ADH secretion? And so if we look at it, if we have a 1 to 2% decrease in our plasma osmolarity, that's going to be a strong inhibition of ADH secretion. And why is it going to be a strong inhibition? Remember, ADH leads to those kind of water, those aquaporins that are going to go into the proximal convoluted tubule and the collecting duct of the kidney. And that's going to allow the body to reabsorb water. Well, if we're getting a decrease in our plasma osmolarity, we don't want to absorb any more water. We want to stop that. So that's going to be a potent inhibitor of ADH. Now, if we have a 1 to 2% increase in our plasma osmolarity, then that's going to be a strong stimulant of ADH. In addition, if we have a 10 to 15% blood loss, so if we're getting a stage 1, stage 2 shock, that's going to be another stimulant of ADH release, and that's how we talked about in those 3 things with the metabolic response to injury. You have pain, hypovolemia, and circulating stuff. That hypovolemia is going to be a strong stimulator of ADH to start reabsorbing water and sodium. And so you might ask yourself, well, how about that patient with low serum osmolarity and a low blood volume? Which effect dominates? Well, in this case, the low blood volume is a greater stimulant of ADH release. And this is one of the reasons why patients with low blood volume are at a higher risk of hyponatremia, because that ADH stimulus for low blood volume predominates despite having low osmolarity. And so here we can get into hyponatremia first. Now, what is hyponatremia? And so if normal is 135 to 145 milliequivalents per liter, this might differ depending on your lab. But hyponatremia is going to be on the low side of that. What are some causes of that? So that would be malnutrition, starvation, water intoxication, burns, also hormones. So ADH is going to can lead to hyponatremia. What are some symptoms? So headaches, confusion, you get cerebral edema, nausea, weakness. Those are just some of the symptoms with hyponatremia. So let's go into the various types of hyponatremia. So whenever you're looking at hyponatremia, first you want to assess your serum osmolarity, and you can calculate that based on the equation I just gave you. And so in the case where you have high osmolarity and you have hyponatremia, that's usually due to hyperglycemia. And we know that for every 100 milligram per deciliter increase in your glucose, you're going to get a sodium fall by about 1.3 milliequivalents per liter. So as the glucose goes up, your sodium is going to fall. And so how do you treat that? Treatment is where you treat the osmotically active agent. So in this case, it would be glucose, and you'd want to treat that with insulin. There are cases where you get hyponatremia and you have a normal serum osmolarity. And when does that happen? That's called pseudo-hyponatremia, and that's in cases of hyperlipidemia or a hyperproteinemia. In this case, it's just an artifact on the lab assay. You don't need to treat it. So let's take the final scenario, and that's where you have a low serum or a low plasma osmolarity. And in this case, you divide that up again. So if we have low extracellular volume, low plasma osmolarity, hyponatremia, that's usually going to be from sodium loss. So for example, nasogastric output, and then resuscitating with hypotonic fluid. So if you have somebody that you're getting a lot of sodium output, then you're resuscitating with a hypotonic fluid, you're going to be giving somebody hyponatremia. The treatment for that is just to give isotonic fluid like normal saline and then do free water restriction. That'll bring those sodium levels up. Remember that sodium problems are usually water problems, all right? And each of these cases will kind of demonstrate that. Take the case of increased extracellular volume. So if you have increased extracellular volume, so that's our edematous states, and you have low plasma osmolarity and hyponatremia, what's the treatment for that? The treatment for that is going to be sodium and water restriction, then usually a diuretic. And that'll bring your sodium levels up. Again, getting rid of water. And then finally, what if you have a normal extracellular volume? You're not hypovolemic or hypervolemic. This is the case in SIADH, or syndrome of inappropriate antidiuretic hormone. So how do you diagnose that? You diagnose that by having three things. One is a low plasma osmolarity. Number two is you have urine osmolarity that's greater than 100. And then three, I should put units on that, so greater than 100 milliosmoles per liter. And then three, you have a urine sodium concentration that's greater than 20 milliequivalents per liter. What's the treatment for that? Well, you just need to treat the underlying cause of the SIADH. Now, I'd like to direct your attention to correcting hyponatremia. And why did I put this picture of a brain on here on general surgery lecture? Well, that's because this particular brain is an example of something called central pontine myelinolysis. And this is what happens if you correct hyponatremia or hypernatremia too fast. So let's go through how you would actually correct a sodium deficit. So correct the sodium deficit is equal to the total body water times the desired sodium minus the measured sodium. So let's say you want to get a safe correction of a sodium deficit. So safe correction would be 0.60, which is the total body water, times the lean body weight, times a desired sodium. And that level, a safe level, would be bringing it up to 120. You don't need to bring it up to 145, minus the serum sodium. So if we do that, in an example, a 70 kilo person, that's what we'll just use every time. So 0.60 times 70 times 120, which is our desired sodium concentration for a safe correction, minus 110, which is the measured, is 420 milliequivalents of sodium. So how do you give that? Well, know that in regular normal saline, there's 150 milliequivalents per liter. If we increase the concentration of saline, so for example, a 3% solution, that's going to be 154 times 3, or 462 milliequivalents. So we could get there and do a safe correction by giving, and we do some stoichiometry here, 909 milliliters of 3% NS solution should bring us up to our 120 level. And I will say this in big red caps, do not increase by more than 10 to 12 milliequivalents in 24 hours or 18 milliequivalents in 48 hours. And if you do, you're going to increase the risk of CPM or central pontine myelinolysis. And that can be a really scary thing, so you want to avoid that. Here, this is a great reference, Braun et al., American Family Physician, a freely available PDF. I'll put the link to it in the description. But this is another kind of algorithm, or treatment algorithm, of how you can correct severe hyponatremia. So definitely check this out, review it, be knowledgeable about that. So if you're correcting hyponatremia, you do it in a very safe way so you don't injure your patient. So now that we're totally comfortable with hyponatremia, I know that was a little bit dense and it took a bit, but you should be totally confident now. We can go to hypernatremia. Now, hypernatremia is much less common, and this is usually caused from excess volume loss. So from temperature, excess insensible loss. So that can be caused by fever, hyperventilation, and burns, or hypotonic fluid losses like increased perspiration from increased temperature and severe loose stools or severe diarrhea. That can lead to extra volume loss, which are the principal causes of hypernatremia. In addition, interventions can cause hypernatremia, so high salt diet, medical interventions with greater than 3% normal saline. So if you're trying to give hypertonic saline to lift the sodium in a TBI patient. That can be a cause of hypernatremia. And of course, some hormones with the renin, angiotensin, and aldosterone axis. And then what are some symptoms? So symptoms of hypernatremia are going to be things like nausea, dry mouth, fever, agitation. Those will be your symptoms, and those usually don't come on until the sodium level is like greater than 160 milliequivalents per liter. So how do you treat it? So here we go through a nice kind of algorithm on how to treat it. So elevated sodium is usually from excessive free water loss. So fever, hyperventilation, burns, diarrhea. What's the treatment? If you have poor tissue perfusion, you want to just give isotonic normal saline until the tissue perfusion is restored, and then 0.5% or D5 water to return plasma sodium to normal. In an example of polyuria, so maybe that TBI patient, or you gave mannitol, or you have somebody that's hyperglycemia, or you have acute tubular necrosis or central diabetes insipidus, the treatment is giving free water back with DDAVP, and of course treating that underlying cause. And again, we want to avoid rapid correction of severe hypernatremia, and this can lead to irreversible neurological injury. So I don't use red very often, but I used red here because I want this to stick out. So plasma sodium should not be corrected by greater than 0.5 to 1 milliequivalent per liter per hour. And so how do you calculate how much water to give? Well, you can use this equation. So the water deficit is equal to total body water times the plasma sodium divided by the desired plasma sodium minus 1. So we like to do examples so you can plug this in. So let's take a 70 kilo male with a sodium 175. How much free water do you have to give? So in this patient, you would want to replenish their volume with normal saline until you had tissue perfusion, and then you'd want to look at what's their water deficit. So 70 kilos times 0.60 times 162, or their measured sodium, over 140 minus 1 means they have a 6.6 liter water deficit. So could you do this? You could correct this with quartal normal saline at 168 mils per hour. And that would give you your desired plasma sodium concentration. So sodium, that was a big one. Let's go to the next big one. That's going to be potassium. So potassium, we're going to look at hypokalemia, hyperkalemia. So hypokalemia, what's the big thing? The big thing is cardiac disturbances. And what are the causes of this? So malnutrition, starvation, alcoholism, GI loss, renal dysfunction, metabolic alkalosis. Those are the major causes. What are the symptoms? So nausea, vomiting, and of course, our cardiac arrhythmias. So how do you replace this? We usually replace this at about 10 milliequivalents per hour if you have peripheral access. And if you have central access, you don't want to be increasing it giving more than 30 to 40 milliequivalents per hour. So when we look at hyperkalemia or high potassium, what are the major causes of this? So diet, metabolic acidosis, renal failure, trauma would be some of the major causes, as well as excess administration of potassium. If you have a high potassium value on a lab, it can also be because of hemolysis. So you want to find out, well, what was the sample hemolyzed? Because that could be a false reading and give you some false anxiety in your patient. So when we look at correcting hyperkalemia, there are a bunch of different treatments and how those treatments work, and then how long it takes for each of those. And so I'll let you go through this, but you can start by shifting potassium from the intracellular and extracellular compartments. Now, how do we do this? Like, one would be intravenous calcium gluconate. We'll shift this from the extracellular to the intracellular compartment as it antagonizes the effect of hyperkalemia on the cell membrane. And this is going to act in seconds to minutes. All right. And this will go all the way down to things like potassium binding resins or dialysis, where you're actually removing potassium from the body. So when you're using things like calcium gluconate or albuterol, insulin, sodium bicarb, you're just translocating potassium, you're not removing it. And so if you really want to get rid of the potassium, then you do this with dialysis. And so moving on to calcium. So calcium is important in a couple of ways. Number one is to think about the calcium. The only important component when it comes to electrolytes is the ionized form of calcium, because the rest is circulating bound to albumin. So total calcium levels can fluctuate depending on fluid and albumin levels. And so you can estimate what the ionized or the active component of calcium is with this equation right here. And then know that our typical daily intake is 500 to 1,000 milligrams, and most of the calcium in the body is stored in the form of bone. When we look at what are some of the causes of hypocalcemia, so that would be low dietary calcium, low vitamin D, renal dysfunction, increased serum phosphate, low serum magnesium. These are just some of the causes of hypocalcemia. What are the symptoms of hypocalcemia? So those will be things like CNS depression, confusion, disorientation, weakness, can also get abdominal pain, nausea, vomiting. When we look for causes of hypocalcemia, we can think of these, and the most common cause really is low serum albumin, but you also have to keep in mind, like, could it be acute pancreatitis? Could it be a massive efflux from a small bowel fistula? Could the cause be hypoparathyroidism? So the differential is quite wide, and so when you have a patient with hypocalcemia, you really have to take a good history physical exam and understand what are the causes and how you can narrow that differential down. Now going on to hypercalcemia, so hypercalcemia has a huge differential. Hyperparathyroidism and malignant disease are about 90% of all of those. And so what are the symptoms of hypercalcemia? That's going to be your stones, your moans, your groans, CNS excitability, irritability, confusion, lethargy, abdominal pain, all of those. So it's a wide symptoms and a pretty wide differential for hypercalcemia. And so how do you treat hypercalcemia? So hypercalcemia, once you get above 15 milligrams per deciliter, that's when you're going to see those EKG changes, like a shortened QT interval. These patients are going to require vigorous hydration, and once you get them hydrated up, you can diurese them with like furosemide, and that's going to drop that serum calcium level. So we can go through the next few ones a little quicker. So magnesium. So magnesium hypomagnesemia, this is common in patients that are abusing alcohol, and can also be seen in malnutrition, starvation, when you're given TPN, also from different drugs such as aminoglycosides and potassium wasting diuretics like Lasix. Now the symptoms of having low magnesium would be things like neuromuscular excitability, increased reflexes, tetany, tachycardia, high blood pressure. And so when do you fix it? Usually if serum magnesium is less than 1 milliequivalent per liter, you want to replace that. And so if the magnesium level is less than 1 milliequivalent per liter, you want to replace that. And you can replace it with up to 2 milliequivalents per kilo per day in the presence of normal renal function. So going on to a high magnesium, this is exceptionally rare unless you have renal failure. And this can be pretty dangerous. So when you're getting really high levels of magnesium, over 6 milliequivalents per liter, then you're going to get flaccid paralysis, coma, pretty scary stuff. And so how do you treat really high magnesium levels? So you treat that by giving calcium, so either intravenous calcium chloride or calcium gluconate, and that's going to lower those magnesium levels. And then ultimately the treatment to get rid of the magnesium would be intravenous hydration as well as diuresis. Now we can move on to phosphorus, one of our last electrolytes. And we talked about this a little bit in the TPN section, but when you get a low phosphorus, what are some of the causes of that? So malnutrition, starvation, phosphorus for TPN, and of course, big liver resections. Now, big liver resections, because you have so much phosphorus and ATP production to regenerate those hepatocytes, that's how you get that low phosphorus level. And so what are the symptoms of hypophosphatemia? So that would be things like muscle weakness, hypoxia, seizures, and ultimately myocardial depression and cardiac arrest. And so if you do want to replace severely low levels of phosphate, you can do that with potassium phosphate diluted in IV fluid. You do it at an amount of 0.08 to 0.16 millimoles per kilo over 4 to 6 hours. Look at it, hyperphosphatemia. When do you get this? You get this usually with renal impairment. You can also get this in hypoparathyroidism, where you get reduced phosphate excretion. And the treatment of this is really to address the underlying cause. All right, dense topic, a lot of information, but you can watch this, you can review it again. I'm also gonna have a review sheet available. You can check that out at citizensurgeon.com. There's a lot of good resources there, totally freely available, so check that out. If you haven't had a chance to subscribe, hit the subscribe button. Also engage, leave some questions, some comments. What are some topics that you want to hear? And then I will totally get back to you. Also, let's finish the day. Let's talk about our clinical case. So let's say you have a 17-year-old male who has ulcerative colitis, and he came in, he was transfusion dependent, you needed to do a total colectomy, so you did your total colectomy. He's post-op day 4 now from his operation, and he's had 2.5 liters of osteotomy output a day. He's tachycardic and hypovolemic. Number 1, how are you going to evaluate this patient? Number 2, what fluid are you going to give, and how are you going to determine how much fluid to give? And number 3, what electrolyte disturbances would you expect in a patient like this? All right, that's it. So as we close, definitely check out the videos on surgical nutrition and definitely subscribe to Citizen Surgeon YouTube videos. You'll know when each of these videos are coming out. All right, peace out. Thanks so much for joining us.